including the Arcus Foundation in the United States, but also through trainings that we do and generate our own funding. So we are a collective of about 6 or 7 psychologists across South Africa. And we locate our work within an NGO, which is the Psychological Society of South Africa, which is the nationally representative body for psychologists in this country. So I'm going to speak about queering healthcare, and I'll speak a bit more further down the line about what I mean by queering, because I'm using the word queering, as a verb in this sense. And some of the work I'm presenting today is based on a viewpoint that I'd published along with 2 other colleagues, Joachim and Tetman from Cameroon and Joan Nel from UNISA in Pretoria, which was published in the Lancet Global Health last year, April. And we published this piece called Queering Global Health. And, while I understand that global health and public health are kind of distinct fields, as it were, there obviously is significant overlap between the two. And the argument that we're putting forward in this Lancet piece is very similar to the argument I'm going to be putting forward today in this presentation, which is that kind of queer context or queer thinking tends to be missing from public health interventions. And when I say interventions, I'm talking quite broadly, all the way from the classroom to large-scale public health interventions, including research, writing, teaching, supervising, etc. And we need to think a little bit more critically about how we include people who are variously labeled as lesbian, gay, bisexual, transgender, intersex, queer, asexual, etc. And obviously, we know that that acronym is kind of, in some sense, ever expanding, and we need to think more broadly about sexual and gender diversity. And how do we think about sexual and gender diversity in a public health context? So I'll start with some definitions because, I think the trouble with this kind of work is that it's cross-disciplinary. And people come with different levels of understanding and expertise. And so for some of you sitting in this room, you might already be experts in this area. And so a term like hetero-cis-normativity might be quite familiar. And with others, perhaps it's not a term that you're familiar with. So I think I'll just start with some definitions. I prefer to use the term hetero-cis-normativity, even though most writing would probably use the terms heteronormativity or cis-normativity separately, because they obviously mean different things. But I do find hetero-cis-normativity as a kind of broader umbrella term for both of those forms of discrimination. So heteronormativity quite simply means working on the assumption that being heterosexual is the kind of normal default setting for human beings, that it is and I say normal in inverted commas, the normal sexual orientation, and that all other variations of sexuality, whether it's being gay or lesbian or bisexual or asexual or pansexual, etc., are all deviations from this norm. And this results in various forms of then heterosexism. And these can be in the forms of microaggressions where they're quite subtle and people might even deny having done them, or they can be macroaggressions or overt prejudice or overt discrimination and stigma. Cisnormativity has a lot more to do with gender rather than sexual orientation. So cisnormativity is this assumption that being cisgender is the kind of normal setting for people, the normal default experience for all people. And being cis, CIS, means that your gender identity and the way you express your gender aligns with the biological sex that you assigned at birth. And this then results in forms of cisgenderism, because we often assume that the way someone looks on the outside must therefore match essentially what's in their pants, their biological sex. And so when we think about the combination of these two things, we end up with hetero-cis-normativity. And using one definition from Worthen, it's the kind of systems of norms, values, assumptions, privileges, and oppression that situates heterosexual cisgender people above all others. So there's this hierarchy of human beings, of which heterosexual cisgender people are right at the top, and then places all other people who fall within the sexual and gender spectrum, lesbian, gay, bisexual, transgender, intersex, queer, etc., in a place of systemic disadvantage. And these, like I said, can happen in all sorts of ways. And most often I find, especially in public health thinking, they are often heteronormative assumptions that are implicit rather than explicit in the way in which we think about and do our work. And so I suppose as I'm going through this presentation, we all can think about the ways that we inadvertently use hetero-cis-normative assumptions in the way that we work. And this often has nothing to do with whether the person themselves is even part of the LGBTQ plus community, because we are socialized and trained into thinking with heteronormative and hetero-cis-normative assumptions all the time in public health work. So there are many problematic public health assumptions, which if we, and I suppose don't have to even dig deep enough, if we just scratch the surface, we will see that they exist quite blatantly in the training, in our textbooks, in interventions, etc. So public health training and interventions, they often assume a particular type of citizen. They assume that the beneficiary of any public health intervention is often going to be straight, cisgender, in a monogamous relationship, and with a fixed identity over time. And this then results in very narrow conceptual binaries, which also remain quite rigid in public health thinking. That even where you accept that there is diversity, this diversity ends up being in binary fashion. That you're either heterosexual or you're gay, you're either male or you're female, you're either masculine or you're feminine, you're either single or you're married, you're either a mother or a father, etc. And so heterosis normativity relies on us perpetuating these binaries in all sorts of ways and in all sorts of fashions. And I think the binaries I find often more important to think about critically, because even where we might think that we're liberal and even where we might think that we are being quite inclusive, you often find that these binaries still exist, sometimes in very simplistic ways. For example, forms that still only have male or female, or a kind of hotter issue right now, public bathrooms and, whether there's a male bathroom and a female bathroom. But they might also be in much more subtle ways, where we assume that every child that gets seen must necessarily have a mother and a father, even if that father is absent, for example. That the assumption that this person might have two fathers or two mothers often doesn't exist. And that if someone is male, they must be masculine presenting. That if someone is male and they're feminine presenting, it must automatically mean that they are gay. And that if a woman is more masculine presenting, it must mean that she is lesbian. And what I mean when I talk about fixed identity is that if someone therefore does say that they are masculine, or if someone does present as masculine today, that identity will remain static over a period of time. So rather than thinking about people as fluid, as expansive, and as changing throughout the developmental course of their life, we often make these assumptions about people based on particular points of interaction, and we keep those assumptions fixed over a period of time. And these can be problematic for a whole variety of reasons. So we know that heterosis normativity has real tangible effects. And a variety of systematic reviews and meta-analyses show that. So research consistently shows that LGBTQ plus people experience discrimination in healthcare settings, and this results in poorer health outcomes, both globally, if we look at recent systematic reviews, but also in South Africa, if we look at studies done by Luvono and Molo and News. A meta-analysis, a bit of an old one, but I think the results probably still hold true, from 10 years ago of over 300 studies across 19 countries, show that LGBT people reported, at least 55% of them reported verbal harassment, 45% experienced sexual harassment, and 41% experienced discriminations at much higher levels than the general population. So there is minority stress. And in a review of 57 papers by Zeman et al., the root causes of health inequalities for LGBT people were found to be thematized in 5 areas: cultural and social norms that prioritize heterosexuality, minority stress, where LGBT people experience a disproportionate burden of stress compared to their heterosexual or cisgender peers, overt victimization, including in healthcare settings, discrimination, again, also in healthcare settings, and stigma perpetuated by healthcare workers. So, based on the data that we have, we see that heterosis normativity is not simply ideological then, that it has real world effects. It actually does affect people's healthcare and well-being, and can even affect mortality and morbidity. And of course, some people will then claim that, well, we do have key populations and that, we do include LGBTQ plus people under this banner of key pops. And, there is a problem with key pops, and there's a lot of critique around even just the term key populations or even the conceptualization of key populations. And I've got some references down here, if you're more interested, by Young and Mayer, and a more recent one by Andrew Tucker. So, the problem with men who have sex with men or women who have sex with women, although that's used less frequently, is that they're often reductive labels of sexual behavior. So they focus exclusively on behavior and what people actually do with their bodies, as opposed to identities, which are much more linked to people's kind of psychosocial well-being. And the second point is that key pops also tend to be homogeneously lumped together, and are conceptualized as people who are at risk. And the idea of being at risk can also then further stigma, further prejudice, further discrimination, even though it's done under this kind of benevolence of reducing deviant behavior. And there's all sorts of kind of ideological problems with that as well, including theoretical problems. Obviously, there's also this enduring association and stigma that comes with associating key populations with being at a higher risk of contracting HIV. And it's linked to the era of HIV and AIDS care as well. And, more importantly, I think, especially for me as a psychologist, such terms are rooted in a particular public health language that actually sit quite awkwardly with more nuanced and diverse self-identifications amongst LGBT communities who often would never identify as an MSM or a WSW, even though they are then forced to co-opt these labels and forcibly identify with those labels in order to benefit, and I say benefit in inverted commas, benefit so that they can gain access to healthcare services that they otherwise wouldn't get access to, such as access to PrEP or ARVs, etc. in some contexts. And in some countries where um, just simply being LGBTQ plus is criminalized, like Uganda and Nigeria, etc., or even in Cameroon, the only way to access any kind of healthcare service is then to identify as one of these key populations, even though it doesn't actually fit the person's self-identification, which then reduces the person's dignity and it reduces the person's autonomy as well. And as Andrew Tucker argues, these categories are unable to deal with broader issues like cultural, social, and community complexities. And they, at the theoretical level, they lack explanatory power because they essentially only focus on behavior, which is sexual behavior. So, if I can just zoom out a little bit, so there's very lofty global public health goals. If we read documents by the World Health Organization, if we read like the Sustainable Development Goals, if we read think pieces that are published in high-end journals around public health and global health, we see that there's a lot of promise being made to improve the health of people who identify as LGBTQ+. But despite all of this, there seems to be persistent global inequality for LGBTIQ plus people. And the stats don't paint a very promising picture. So if we look at United Nations member states, out of the 193, 35% criminalize consensual same-sex sexual acts, and 33 of them are in Africa. If we look across Africa, consensual same-sex acts are legal in only 22 out of 54 countries, which is less than half of Africa. And punishments are not just life imprisonment, but they include death in 10 countries. And in Africa, specifically Nigeria, Mauritania, and Somalia, and more recently, Uganda, where their new Anti-Homosexuality Act has the death penalty in certain instances, which has direct implications for public health. So, for example, in Uganda right now, if two gay people are caught having sex, they can be sentenced to life imprisonment. And if someone is caught having sex while they are HIV positive, this could result in the death penalty. If we look at gender expression, 13 countries right now criminalize gender expression of transgender people. 9 of them are in Asia and 4 of them in Africa. And globally, only 11 countries actually protect the right to sexuality in its national constitution. And if you look at that list of countries, they're not countries that we would actually think are countries that are protecting sexuality in the national constitution. Countries like Bolivia, Cuba, Ecuador, Fiji, and South Africa is in that list. And as many of you might know, South Africa was the first country in the whole world in its interim constitution in 1994 to actually protect sexual orientation in the national constitution. And led the way in this regard. But still, this only represents 6% of countries in the world. So the picture is quite bleak, as it were, from a legislative point of view. And if you look at this map, just graphically, wherever you see purple, it means that LGBT people suffer criminalization of some sort. And unfortunately, the majority of these countries seem to exist in the global south. And this is why in the title of my presentation today, I mentioned how we can challenge not just hetero-cis-normativity, but also coloniality. And often people do not make the link between hetero-cis-normativity and coloniality. But in fact, coloniality is one of the, I would almost say, the precipitating factors that led to a lot of the anti-gay and anti-trans laws that we see across Africa. Most of these laws were brought in by European colonialists and did not exist in a formal legal manner before colonialism. And so when we think about undoing colonialism, when we think about decolonizing public health or even just decolonizing healthcare in general, we're not just talking about undoing legacies of racism. We're also talking about undoing legacies of patriarchy, sexism, and hetero-cis normativity, because all of that is part and parcel of the colonial logic that was enforced on African countries. And across Africa, if you're following the news, there is a rising LGBTIQ plus sentiment. And in fact, right now, in Uganda, especially because of the Anti-Homosexuality Act, people are being prosecuted as it stands. With our colleague from Cameroon, who we wrote the Lancet paper with, um, public health facilities have to find all sorts of roundabout creative ways in order to give access to healthcare for LGBTQ plus people. And in Nigeria, there's an explicit mandate that people must be jailed or persecuted or even killed simply for being who they are. And in South Africa, despite our progressive laws, in fact, we have the most progressive laws in the whole world when it comes to LGBTQ plus people. There probably isn't a single legal protection that LGBTQ plus people do not enjoy in South Africa. But despite that, Human Rights Watch accused South Africa in 2011 of not doing enough to stop the epidemic of violence against LGBT plus people in the country, especially the murder of lesbian women in this country. One study from 2014 found that 69% of South Africans were not accepting of sexual and gender diversity. In other words, they held very rigid hetero-cis normative assumptions. And in a nationally representative study of attitudes towards LGBT plus people, which was conducted by the Other Foundation, 72% of South Africans felt that same-sex activity is morally wrong, even though at least half the country felt that gay people should have equal rights. So there is a little bit of contradiction in the kind of attitudes that people hold. And in a recent study around hate crimes, out of almost 1,000 hate crimes that were reported, 17% of them were based on sexual orientation and 11% of them based on gender identity or expression. They were only exceeded by hate crimes based on xenophobia in South Africa. So after xenophobia, the most number of hate crimes reported in South Africa are based on people who are LGBTQ+. So despite the progressive laws, attitudes and values in South Africa remain highly conservative. And one of the arguments that we constantly hear to explain why these attitudes are so conservative is that it's against my culture, whatever that culture might be. And this is an argument that's heard over and over again. But if we interrogate this argument, there's actually no historical, sociological, anthropological, or even good scientific evidence for this. In fact, quite the opposite. There's a long history of fluid sexualities and gender expressions in Africa before the colonial powers came into this continent. In fact, homophobia is better conceptualized as being un-African, because that was a foreign attitude imported by colonial missionaries. And so this argument that it's against my culture is actually intellectually lazy. It's a collective denial of history and a collective denial of science. And, Thabo Msibi's article, The Lies We Have Been Told on Homosexuality in Africa, is instructive here, and I would highly recommend as good reading. And so when we talk about, therefore, decolonizing, we have to also think about how certain colonial tropes have actually been internalized, and we have been led to believe that these colonial ideas are in fact true, and in fact, ironically, represent indigenous culture, when in fact the opposite is true. And there's a lot of scholarship in this area, work by people like Sylvia Tamale, Stephen Murray, Will Roscoe, etc., Jane Bennett, explore the idea of sexual and gender diversity across Africa, looking at it historically and in the more contemporary era. And of course, what this means is that most people, therefore, who are LGBTQ plus remain in what we call the closet. And we often think about, or we talk about people needing to come out of the closet, but we don't often talk about the idea of the closet being a public health issue. And work by people like Pachantkas and Brandstrom are quite impressive, where they've tried to calculate the size of the global closet and the public health impact that it has. And this is a really good paper, highly recommended, published in PLOS One. And based on their estimates, using all sorts of impressive numerical data across many years, across many countries, they estimate that 83% of the global LGB plus population, and they specifically only looked at sexual orientation in their study, lesbian, gay, and bisexual people. They didn't look at transgender people, intersex people, and queer people more broadly. But their study showed that at least 83% of LGBT people conceal their sexual orientation because of stigma. And the highest proportion of concealment is in the Middle East and North Africa, and followed by sub-Saharan Africa. And that's a whopping number. I mean, 89.5% of LGB plus people in sub-Saharan Africa are estimated to remain in the closet out of fear that if they come out of the closet, they will be subjected to prejudice, discrimination, stigma, and in some instances, even violence. And if we compare this to other contexts like Western Europe, Latin America, and the Caribbean, the number is far lower. And we know that based on systematic reviews, sexual orientation concealment, in other words, remaining in the closet, has been linked to depressive symptoms, anxiety symptoms, substance abuse, relationship difficulties, susceptibility to infectious diseases, and premature mortality. And according to Pachantkas and Brandstrom, to alleviate the toll of the closet, we need to develop public health interventions that sensitively reach the closeted sexual minority population, especially in high stigma contexts worldwide. And I think in our context, I'm thinking specifically about countries that criminalize simply being gay, lesbian, or bisexual or transgender right now. And how do we reach those what we call hidden populations in contexts where even reaching out for healthcare can land you in jail? As it stands, if a patient comes out to their psychologist or healthcare provider in Uganda, the healthcare provider is compelled by law right now to report that patient to the police. And if they don't report them to the police, the healthcare provider can be imprisoned for up to 5 years. So what is the impact then in terms of ethical public healthcare when legislation forces people to remain in the closet and then prevents them from accessing decent healthcare? And if I come closer to home, the history of psychiatry and its impact on public health cannot be overstated, because psychiatry has played a significant role in pathologizing and even helping criminalize LGBTIQ plus people. And I'm not going to go into this in any significant detail, but suffice to say that certain disciplines have also fed into public health thinking that's become quite normative, even in the contemporary age, as we've changed our thinking. If we think about the DSM, for example, the Diagnostic and Statistical Manual, in its first version, anyone who was LGB in the 1950s would have actually been diagnosed with a sociopathic personality disorder. And there was even a special category called sexual deviations. In the second edition in the 60s, this now became sexual deviation personality disorder. In the 1970s, this became sexual orientation disturbance. And you know what's really interesting is that it was only in 1973 that the American Psychiatric Association removed homosexuality from the DSM and removed it as a psychiatric disorder. But and there's a long, interesting history about the committee that voted for this. And I think what this speaks to, especially in terms of public health issues, is how the removal of homosexuality was not a scientific or public health debate. It was essentially an ideological debate. And in the end, a voting majority got to decide whether something like homosexuality remains in the DSM or not, and by a very slim margin of only 58%. So by a simple vote of a simple committee, an entire disorder got removed from the DSM with major public health implications. Because the very next day, the Chicago Gay Crusader, a newspaper for LGBT people, reported, quite tongue-in-cheek, that 20 million gay people are now cured. How is that for a public health intervention? That you can simply, by vote, remove an entire disorder from a diagnostic manual and cure 20 million people at the flick of a signature. In the 1980s, they then bumped it up to ego-dystonic homosexuality. So because being homosexual wasn't a disorder anymore, it had to be ego-dystonic. In other words, you had to find distress with your sexual orientation in order for it to be a diagnosis. Now, we can already see the problem with that. If we think about the global closet and the size of the global closet, that the size of the global closet was even higher in the 1980s. And it's hard to imagine anyone being gay, lesbian, bisexual, or transgender and it not being ego-dystonic in some way, and therefore them not meeting the criteria for the psychiatric label anyway. In the revised version, this now became sexual disorders not otherwise specified. I think as ideology progressed and people became a bit more liberal, the idea of having a diagnosis because of your sexual orientation changed in the 90s with the DSM-4, and the focus became a lot more on gender. And we see the enduring effect of this even today. The kind of culture war right now is less about sexual orientation and more about transgender people. So, and you can see how this is linked to changes in the DSM and how things like the DSM don't just affect psychiatry and public health. They affect how broader culture around the world think about people's identities. Because from the 90s, gender identity disorder became much more prominent. And in the latest version of the DSM, DSM-5, we now have gender dysphoria as the most prominent disorder. So the focus evolved from a focus on sexual orientation to now a focus on gender diversity. And so this is why I prefer using hetero-cis-normativity as one long term, even though it can sound a bit clumsy at times, because there is a combination in the end around how heteronormativity, as seen through the DSM, and now cis-normativity, seen in later iterations of the DSM, kind of like work together to inform public health issues. And this, article by Cooper, I think is quite interesting. And one of the important quotes of here has to do with how we think about disorders in the DSM and its ability to do harm. And one of the things that Cooper says is that often changes to the DSM relating to the conceptualization of harm have come about in ways that are almost accidental. The committees revising the DSM have often failed to appreciate the importance of conceptual issues. And I think the phrase almost accidental is quite important because we see how major decisions that affect entire communities of people across the world, the LGBTQ plus community in particular, does come about almost accidentally. That peripheral decisions made by particular people on particular committees can influence mortality and morbidity across the world. So it has grave implications for how healthcare is thought about around the world, which means that healthcare is not done in our idealized evidence-based manner in the ways that we think they're done. They're often done based on who's in the room, who's making decisions, who's voting for changes to be made, etc. This almost accidental change that goes about. And the American Psychological Association a while back urged people that we should, all healthcare providers should provide clients with a much more complex theory of gender that affirms a wider range of gender diversity and expands definitions and expressions of masculinity and femininity. And I think this has direct implications for public health thinking as well. Are we conceptualizing public health interventions using complex theories of gender? Or are we relying on those narrow binaries that I spoke about earlier? And it seems like pop culture seems to move faster than public health culture. So pop culture seems to move at a much faster pace. And if we take Facebook, for example, all the way back in 2014, Facebook heeded the call for having a more expansive gender definition. That if you signed up to Facebook in 2014, you were given 50 gender categories to choose from on the drop-down menu. If we think of simple public health surveys, people moan and groan about just including 3 or 4 categories and how it'll add too much of unnecessary complexity to that. So it seems like pop culture and technology catches up much faster than so-called evidence-based public health interventions. And now we are in a situation where we have an endless taxonomy. And some people cite this as a problem. Um, the disparaging phrases like the alphabet mafia are often used to describe the LGBTQ plus community because the letters are ever expanding. People often complain about being too confused. People say that they get nervous about using the wrong phrase, etc. But this is the good thing, obviously, because what this means is that there's an increased sense of autonomy by LGBTQ plus communities to self-identify, to self-label, and rather than having categories thrust upon them, like key populations or sexual deviance, etc., that people are taking ownership for how they want to label, what they want to call themselves, and what kind of terms that they are comfortable with, which increases dignity, not just psychosocial dignity, but also dignity in public health. And I think one of the challenges all of us have working in the public health sector is how do we accommodate for this diversity? How are we inclusive and expansive? And how are we ensuring that our public health thinking and interventions also kind of move with the times and can appreciate the individualized nature of self-identification while balancing out the kind of more universal public health goals that we all have that have to accommodate larger populations rather than just narrow individuals. And one way to do this is, we need to think about how we can be radically intersectional, and I'm sure, people are familiar with the idea of intersectionality, the idea that we have to accommodate, as many different categories of identity as possible if we want to create a truly inclusive public health culture. And, Xavier Liverman writes quite nicely about the idea of queer visibility. And I highly recommend the one paper by Liverman called Queering Freedom. And Liverman's writing about what it means to be Black and gay in South Africa. And, on the surface, it might not seem like this has anything to do with public health, but I think it does, because Liverman's talking about how we create visibility in contexts where there might not be enough social and cultural capital for people to actually feel comfortable to actually be visible. And I use this photograph deliberately because this is a photograph of the first openly gay Zulu wedding that took place in Pongola in KwaZulu-Natal many, many years ago. And it was shared all over the media. The news, SABC News covered the wedding, and the community really came out in support of these 2 young men, which was quite encouraging. And, Liverman says that middle-class Black queer people struggle to access the human rights in our constitution, not because there's a lack of material resources, but because there's a lack of cultural resources, where Blackness as an identity seems to cohere around heteronormativity. In other words, and this is where the decolonial idea comes back into play, is that we need to separate the idea that being gay or lesbian or transgender is a Western white phenomenon, that it's against my culture, that Blackness is almost instantly linked to ideas of being kind of like masculine or straight or cisgender. And I think in a country like South Africa, where we are culturally, linguistically, ethnically diverse, we need to think quite critically then about how we have an intersectional approach in our public health work, where race, culture, and sexuality are able to come together in ways that are meaningful for the public health interventions that we create. So basically, I know I'm giving a lot of information over here, but the kind of basic argument is that the problem is that public health tends to function from a position of hetero-cis-normativity, and that this is then reinforced by healthcare worker training and practice. So we also then need to think about health professions education and how we can change that, and public health training and education, and that these attitudes are actually an enduring effect of colonial era laws and values. So part of changing our attitudes towards LGBTQ plus people is also about decolonizing our own mindsets, decolonizing our own curricula, decolonizing our own interventions. And so the idea of ending heteronormativity cannot be separated from the idea of decolonizing, well, just about everything in society. But all of this then results in a vicious cycle of inequity for LGBTQ plus people, which results in poorer health outcomes. So all of them is then linked to a public health agenda. But fortunately, because I am going to end on an optimistic note, fortunately, there are a growing number of guidelines that really speak to this and provide us with the kinds of material, pragmatic, theoretical, and clinical resources that we actually need to advance a queer agenda. And I use the word queer in my own writing and my own work as a broad umbrella inclusive term to refer to sexual and gender diversity. So we've got the Academy of Science of South Africa that published a very important report on diversity in human sexuality. We have the practice guidelines for psychology professionals working with sexually and gender diverse people, of which I was one of the co-authors. And although we wrote it for psychology professionals, it's been co-opted by a range of healthcare workers across various contexts and across various countries as well, including Cameroon and Nigeria, and it's even been translated into multiple languages. And most recently, the Southern African HIV Clinician Society released gender-affirming healthcare guidelines. And this was done in collaboration with a range of organizations, including the Professional Association for Transgender Health in South Africa, which is a really amazing organization. And I highly recommend people joining PathSA as well. This is just a photograph of my colleagues who are part of the African LGBTI plus Human Rights Project. We're all based in various institutions across the country, but we try to come together about 2 times a year to collaborate on important work around how to queer not just mental health, but also kind of public health more broadly, as most of us are situated in public health spaces. And some of the outputs, the academic outputs that we've had, is a position statement that emanated from the Psychological Society of South Africa about how sexual and gender diversity needs to be put onto the agenda for mental health professionals. And then the practice guidelines, which we launched in 2017, and we're currently in the process of revising. So the second version of the practice guidelines will be launched next year in June. And these guidelines have served as an epistemic resource for thinking differently about ethical practice and for undoing patriarchal and hetero-cis-normative assumptions, not just in the field of psychology, but also in public health more broadly. And I think one of the questions that I often grapple with is how we can globalize our work from Africa, for Africa, in Africa, and with other African colleagues. Because when we think about global health, especially, and especially global public health, we often find more often than not, it's about African contexts importing Western initiatives or adapting Western initiatives. Whereas, our guidelines, we've conceptualized them as an African-led initiative that has been globalized within the African context. But how then do we use things like affirmative guidelines in contexts where there's actually explicit discrimination and where this discrimination remains a colonial continuity without the politicians who are implementing these laws even seeing it as an extension of coloniality. And again, Uganda as an example, Yoweri Museveni, the president, keeps saying that being LGBT plus is a Western import, forgetting, in fact, that the laws he's implementing were brought in by British colonialists to begin with. And so I'm going to just end with a little bit of a note on terminology. I sometimes start with this, but I sometimes end with it because I never quite know where to put it. Because, part of queering public health is becoming comfortable with a very expansive vocabulary. And I think part of the resistance or the reluctance to engage in this work is because there is some reticence about how to engage effectively with the terminology. And of course there's variations of the acronym of LGBT plus, and you'd notice even through my own presentation I've kind of fairly inconsistently referred to the terminology, and people use different acronyms or different terminology for different purposes, provided that it's justified, it's explained, and it's inclusive for the purposes that one is doing the work. And so there are different variations, and there isn't a correct acronym. There isn't one officially correct acronym. It just needs to be adapted for your purposes. But most of the variations seem to be something along the lines of LGBT plus, LGBTQIA plus, etc., where sometimes intersex is included, sometimes it isn't, sometimes trans or queer is included, sometimes it isn't. But increasingly, people are also using SOGI or SOGI SC, which I'll explain in a little bit if you haven't heard that. But the World Health Organization, more currently, in their article on improving the health and well-being of LGBTIQ plus people, they say that LGBTQI plus health refers to the physical, mental, and emotional well-being of lesbian, gay, bisexual, transgender, queer, and intersex people. And the plus tends to refer to all other variations and diversities. And they also use sexual orientation, gender identity, and expression as an equivalent term, which is the term SOGI. And the term is quite loaded in many ways because although people tend to use the term, there sometimes isn't a full appreciation of how each of the letters can actually stand for quite various things, not just in terms of what they mean, but theoretically where they're positioned. So the LGB is often about sexual orientation, lesbian, gay, or bisexual. And sexual orientation has to be inclusive of not just sexual attraction, but sexual, romantic, and emotional attraction. And it's very important that when we think about sexual orientation, we don't just think about who people are sexually attracted to. The T is not sexual orientation because it has to do with gender identity and expression, and often stands for transgender. Queer is often a political identity, as it were, because it often refers to a broader umbrella term that can refer to a diverse range of sexual and gender diversity that might have nothing to do with sexual orientation or even gender identity, and might have to do with even relationship configurations. So, for example, whether people see themselves as polyamorous, for example. I is specifically biological because I has to do with whether one is intersex or not. And even then, although the I tends to be included, the preferred term now is DSD, which is diversity of sex development, or differences in sexual development. And the plus is often included as a symbol of further inclusion and further diversity, so that people who don't identify with any of the existing letters in the acronym feel that those identities are included as well. Whereas the SOGI or SOGI SC, the SO tends to refer quite specifically to sexual orientation, which is the lesbian, gay, or bisexual. The gender identity or expression can refer to being transgender, but also other variations that might not necessarily be transgender, such as being gender non-conforming or gender non-binary. And the SC refers to sex characteristics, which often is then used in place of being intersex or having diversity of sex development. So ultimately, these acronyms then need to be interrogated and used quite critically for whatever kind of work that we're doing, because there isn't a correct acronym. It's all about what purposes are you using that specific acronym for, And are you being aware that those different letters actually refer to a whole different kind of population groups altogether? And that we're not just lumping everyone who is sexually or gender diverse into this acronym and thinking we're being inclusive, because then ironically, we're actually doing the opposite. So to end, in conclusion, how can we queer public health? And what do I mean by queering public health? And I'm using queer as a verb here. And so I'm going to draw on the work of Zetu Matabeni and Jabu Pereira, who says that to queer is understood to be an inquiry into the present. To queer is a critical space that pushes the boundaries of what we embrace as normative, to speak back to hegemony, and to challenge various norms on gender, sexuality, and existence and being. So it's quite a loaded definition of what it means to queer something. Um, Melanie Judge writes that we need to bravely transgress boundaries as radical processes of queer disturbance. And I like the phrase queer disturbance. More simply, I would say that what this means is that in all our work, we need to rebel towards social justice. And I use the word rebel deliberately because some of this work can feel quite rebellious because it goes against normative thinking in public health. It also means that we have to unlearn, especially some of the ways in which health professions and public health training and education takes place. We have to unlearn certain assumptions that have become taken for granted. And ultimately, I think our job as people in public health is always to provide hope for those who have lost it. And if we go back to the massive size of the global closet and the high mortality and morbidity rates that it has, providing hope then is an essential part of queering public health. Because we have to provide hope for people who might not have any hope. So this is a call to action in a sense. It's a call to action for public health specialists, all of us, to be socially relevant, but also clinically useful for LGBTQ plus people. Our approaches need to be affirmative, and it must conscientize us to the socio-political determinants of health. And obviously, I'm speaking to the convertative here or the choir. This requires multi-level, interdisciplinary, intersectoral collaborations in how we work, how we write, how we teach, how we intervene, how we design programs, how we write policies, how we do research, and how we make funding decisions. So I'll end over there. There are some resources which I can share with people, some further readings if people are interested, and some of the references that I've alluded to in this presentation. And I think we've got about 10 minutes for any questions. And feel free to reach out to me if there are any conversations people would like to take further, any opportunities for collaboration. And once again, Ushma, thank you so much for inviting me and giving me the opportunity to speak to your esteemed department. Thanks.
Suntosh, that was fantastic. Thank you so much. Such a provocative and challenging presentation. So much to think about, just so fundamental to our very, identities. So I'm really grateful. I see we've got quite a few comments already in the chat that you can look at, but also some hands up. So I'm going to start with Nisha. Nisha, go ahead.
Yeah, thanks, Ushma. Hi, Santosh. That was really a wonderful presentation. It was excellent. It was really clear. It was comprehensive and thought-provoking. I'm Nisha. I'm a public health physician at UCT, and I'm quite involved in undergraduate public health training. So I'd really like to include this thinking in our teaching. So I just had two, I'm sure they're fairly quick questions. Firstly, with many of the public health measurement tools, they often measure sex assigned at birth specifically and not gender because the purpose is to look at biological associations with health. So the categories are typically male, female, intersex, and other. And I just wanted to know what your thoughts were on that, and and for our future kind of development of measurement tools and so forth. And then in terms of key populations, I agree with you that it's very limiting to sexual behavior, but it could be argued that this is needed for targeted interventions and health promotion amongst those who are higher risk of illness. So I just want to get your thoughts on how one addresses that public health aspect while still respecting the dignity of those whom, participating in the research, and practically how should we change the key population terminology, because it's really it's so common in HIV research. So I'd really appreciate your thoughts on that. But thanks for a fantastic presentation.
Oh, thanks, Nisha. Geez, you've asked the $2 million questions. So, I mean, I definitely can't do justice to any good answers. So I'm gonna disappoint you, unfortunately. But those really are like the $1 million questions, which is really about how do you include expansive vocabulary and terminology, in kind of public health metrics, because we can't everyone. So how do we make people feel included? I mean, the latest census was a good example of a really lost opportunity, because it only comes about every 10 years, and they didn't include any sexual or gender diversity questions in the census at all, which was a really lost opportunity. But I mean, I think there are many attempts at people at least including sex and gender as separate categories. So I mean, I think that's the most basic starting point. I mean, the most basic starting point will be that there's a separate question for sex and a separate question for gender. And obviously, public health specialists hate open-ended questions because it makes data analysis near impossible. So I would say a starting point will be at least separating sex and gender, and then at least including someone in the development of whatever tool is being used, as a representative of at least an organization that kind of speaks to these populations. So I mean, I think that might be a starting point. At least making organizations feel like they had a seat at the table, rather than the fact that metrics or questions were created on their behalf and now they're forced to fit into these things. Because I think ultimately, I think even LGBTQ plus people who are public health specialists themselves might also realize the complexities around those things. Yeah, it's a very tricky one. I mean, the key pops, I mean, obviously there's immense benefits. There's no doubt about it. Yeah. So I think I put up that slide just to be a bit provocative around how we can think more critically about it. But it's certainly not an argument that we must give up the idea of key populations, because we know that they have good health outcomes when people are specifically targeted. But I think it's just about having that sensitivity around how it can reduce dignity. And I think that's where the challenge is, that if I have to identify as an MSM just to get access to PrEP, when it's not my identification, what does it do to my dignity then? And then maybe we have to then create interventions around that. So I don't know, those are not very clear answers, but like I said, you unfortunately asked the $1 million questions. So when you do find any answers, please pop me an email.
Thanks very much.
Thanks, Nisha. Virginia, go ahead.
Yeah, thanks. Thanks for a great presentation. Virginia Zwigenthal, also a public health medicine specialist. I had a fantastic PhD student who completed at the end of last year. She did research in Kenya on women who have sex with women to find out what basically their life stories, their health challenges, some of the internal issues that they faced. And the findings for me were quite surprising. Okay, so Kenya is a repressive society. It's basically outlawed to have sex with anybody of the same sex. She found, firstly, the networking amongst women to recruit that she found through trying to recruit people for her study was astounding. She aimed to get about 400 people to respond to her questionnaire, and she almost got it within 48 hours. We thought it was going to be a difficult struggle, but people are unbelievably networked and right around the country. So I think including people who are affected is an absolute must in any initiative for development of policy and programs. And it really shone through her study, which was in a repressive state. Secondly, just about key populations. Lesbian women have often been seen as having no risk for HIV, but in fact, the prevalence of HIV amongst women who identify as lesbians is higher than the rest. It's because in the past they may have had relationships with men. They certainly have children. They certainly have been subjected to terrible abuse, and therefore HIV follows. So leaving people out and only focusing on MSM, I think, is a mistake. So that's the second thing. Then the third thing, the quality of the depth of mental health issues was astounding, and it rests on self-stigma. There's a lot of self-stigma that people have. People are very religious. The traditional churches are very repressive, and so people's self-identity is negative, and they've therefore do substance abuse, have unsafe sex, and so on. People think that women who have sex with women have no need for pap smears, family planning, any of that. That's absolutely not right. It's not true. We need to be much more inclusive and think of the broader health issues that women, I'm thinking about women in this case, have in this world. And then the fourth thing is she had a small sample of transgender men, and everybody thinks that the health issues faced by transgender men is just gender reassignment, baby surgery, inject, testosterone, etc. It's not the case. Many of them still have sex and are need to also have counseling and support for family planning and for pap smears, etc. Yeah. Thanks. Great
Thanks, Virginia.
presentation, though.
Thanks. Very, very useful insights from that study as well.
Thanks, Virginia. Thanks so much. Pancho, we're sort of going a little over time, but I don't want to, I do want to give people a little bit of time to give statements. Thanks, Pancho.
Yeah, thank you. I just wanted to ask very briefly, we see in countries such as Namibia and others that were beneficiaries of the global funding for HIV, that many of these responses, in fact, if I talk about PrEP, is still almost fully funded by the US government. And when we talk about PrEP focused on MSM, or if you want to call them GBMSM, and transgender women, there's no input really from the government itself. Even though the government is procuring the ARVs, the whole infrastructure, the booking system is done by the US CDC. So given we have this situation, what do you see as the way forward? How can we actually mobilize local resources? And then the other quick question is, in the UK census, they actually found that people who self-identified as bisexual compared to gay or lesbian, it was higher in communities of color, particularly Bangladeshi, Indian, or Pakistani, whereas white people tended to be more, lesbian or gay. And those are the only three questions they asked you. You could only be lesbian, gay, bisexual, or straight for your sexual orientation. So what could explain these findings? Thank you.
Thanks, Pancho. I think that my quick response to the first one is that, I think it's just a lack of political will ultimately, because if the entire kind of public health infrastructure for certain issues, like access to PrEP or ARVs or whatever the case is coming from external funding agencies, then governments also become complacent, dependent, and reliant on that. And that also then perpetuates coloniality in a sense, because it perpetuates a particular kind of public health funding model that's reliant on the West. But it's expedient for governments because, hey, it's not their money. And if the West wants to fund access to services for these populations that the government has very little interest in to begin with, then they're willing to take the money and spend it on populations that they ordinarily probably wouldn't spend money on anyway to begin with. So I don't have a very positive view around government's relationship to external funding agencies. And then it's a double-edged sword because, these populations then benefit by being labeled and identified as key populations. They get access to services they ordinarily wouldn't have. But then going back to mental health outcomes, dignity, autonomy, decoloniality, etc., what does that do? And then for all sorts of diplomatic reasons and political reasons, when these countries then have tiffs between each other and there's threats of pulling funding out, where does this then leave these populations? So I think the only sustainable solution is for African countries in particular to have sustainable internal funding models for public health interventions that are not reliant on the West. but I'm not sure if that's ever going to really happen, especially in some contexts. The second question, I've got no idea why people would identify more as bisexual rather than gay or lesbian. I mean, my one answer might be that it might have to do again with the global closet, and that people don't want to identify as gay in certain contexts. I mean, if you take Bangladesh, for example, you mentioned Bangladesh. I mean, it's a majority Muslim country. Being gay or lesbian is not something that one could do without being stigmatized. And I'm not sure if it's criminalized there or not. So, identifying as bisexual might be a middle ground, because one can still have sexual relations with people of the same sex while still maybe also, maintaining a relationship with someone of the opposite sex, because that'll be more socially acceptable. So, perhaps the bisexual identity becomes easier to accept for the individual because of the internalized stigma, the internalized homophobia, and identifying as gay or lesbian might not be something that they will be able to kind of psychologically manage. And I think don't underestimate the public health cost of internalized homophobia. It's huge because it has all sorts of negative mental health outcomes. So I mean, that could be one possible assumption. But thanks, really, really interesting questions. I think I'm going to think about that further as well.
Thanks, Santosh. There is one more hand up, but I realize we're 7 minutes past. Are you okay to take that last question?
Yeah, we can do one more question. Okay. My stomach's grumbling, but I'll manage. Yeah.
And I'm sure the others also need to leave. So I don't want. Is it a short question, please, Landa?
Yes, it's a very short question. Thank you. Very, very quickly. So thank you for that. That's amazing. I'm doing my PhD focusing specifically on transgender, gender diverse populations who are at public universities. My question is, what role do you think that literature that speaks to pre-colonial identities can have in terms of the erasure of trans identities particularly? Because I do know that there's a lot of literature on the broader LGBTQIA+, but it seems to leave trans identities, their specific needs are very vague, because then there's that miscommunication and understanding about the distinction between gender identity and sexual orientation. So how do you think the literature that speaks to pre-colonial diverse identities and sexualities can be used or leveraged for advancing trans research specifically?
Thanks, Leonard. That's such an interesting question. Geez, I mean, I think part of the problem might be kind of oral histories, right? So, and how do we get those kinds of oral histories? My own understanding, but it's a little bit limited in this area, is that there was a greater acceptance around fluid gender identities. And that the only thing that was frowned upon was when the kind of the lineage wasn't passed along. So as long as people had children, it was fine. It doesn't matter what you look like, how you dressed, what your sexual orientation was, who you slept with. Just make sure you have kids, and all other forms of diversity were kind of accepted. They might not have been named or labeled or categorized. And I think that's where the difficulty comes in. So if you're thinking pre-colonial, there isn't a taxonomy of sexual and gender diversity. And I don't think anyone would have identified as transgender, because I mean, to pull in a completely different concept, like if you think of Miranda Fricker's term, hermeneutic injustice, the idea that the words don't exist in the kind of collective imagination, that I don't think if we managed to go back in time, we'd find anyone from pre-colonial Uganda or Nigeria or South Africa saying that I'm transgender. But we'd find people who in today's logic, might fit that description. So I think it's more a matter of how labels have evolved and changed. And I find the resistance, if I look at, for example, India and issues around the third gender and Hijra communities, the issues around now using Western labels, and even transgender for that matter, might be a Western label, where there might be pre-colonial diverse ways of identifying or labeling that have now been lost, because even the phrase LGBTQ+ has become this almost colonizing, homogenizing phrase. And I think we must also be critical about using the phrase LGBTQ+ as if it's this like wonderful inclusive term, when in fact it might erase a whole bunch of pre-colonial identities that existed long before the West decided to call us lesbian and gay and bisexual and transgender and all of that. So even queer, although I use the word queer in all my writing, I use it very critically and tentatively and a little bit nervously. But anyway, that's my short answer. I'm not sure if it's an answer.
Suntosh, thank you so much for a fantastic talk. I think you can see that it was really very well received. People are going to be looking back and sort of looking at your recording. It's going to be on our website. So
okay.
Sorry, I forgot to mention that, and that was my bad. But
it's fine. It's like, oh, you're on candid camera.
I hope that's okay. But
no, it's fine.
Really,
it's fine.
Really, thank you, and I'm sure that people will be able to reach out to you, perhaps if they want to get more information. Please feel free to contact me or anyone in the Transformation Committee. Thank you so much, Suntosh. Enjoy your lunch. Well done.
Thanks, everyone. Thanks, everyone. Thanks, Ushma. Bye. Have a nice day further. Bye-bye.
Thanks, you too. Bye. Bye, everyone.
Thanks, Ushma. Bye. Bye, everyone.
Bye.